many of you are familiar that Kevin O'Connor, after 30 plus years in the field of organ donation and transplantation, has retired, and we could not be more excited to welcome our new president and CEO, Santok Gill. Santok comes from us with, with more than 2 decades of healthcare, organ transplantation, and senior leadership experience, most recently serving as the Vice President of Patient Care Services at Virginia Mason. And recognizing this is just day 2 for Santok, we wanted to give him the opportunity to say hello. So Santok, over to you.
Thanks a lot, Dominic. And Lonnie, I also want to express my sincere gratefulness for you sharing your story. Good afternoon, everybody. My name is Santok Gill. As Dominic said, I spent my last 13 years at Virginia Mason Medical Center, including with the renal and pancreas transplant program. You know, I'm immensely honored to have been selected as the successor to Kevin, who's done just a remarkable job. And I look forward to continuing to grow the program. And I want to just start by acknowledging all the hospital leaders on this call and how you've supported your teams and your organizations through the response to COVID. And it's been with compassion. It's certainly been a long and arduous journey. And I just wouldn't want to start on this topic without acknowledging just the effort and the hardship that teams have gone through across all of healthcare. And having left the healthcare hospital system just recently, I certainly was a big part of the response when we've got our first case in March of 2020. With that said, there are encouraging signs ahead, and I'm very hopeful and optimistic that teams can feel some sense of relief that we have new tools to fight this pandemic, and I wish you and your teams all the best. Thank you for taking time today to be part of this initiative to end the wait. I hope after the presentation you will agree that there are very reasonable targets that have been set, and that the interventions are very focused. And that gives me great hope that if we are to execute on those plans with your help together as a community, we can save more than 1,000 more lives, similar to the story that Lonnie shared. It's very much within our reach. It's possible. It's not an audacious goal. It's actually one that is driven by our data. We know from our information that we have what we need to do, and it's really about supporting each other, working together collaboratively, and executing to our plan. So with that, I'm going to hand it back to Dominic. I want to thank the LifeCenter Northwest team, particularly Dominic and Rachel, for the work that they've done in hospital development and clinical operations to really distill this down to something that we can accomplish. Please know that you all, as well as the LifeCenter team, have my full support. There's no more important work than improving the number of donors that we have so that we can save lives for people who are waiting on the wait list. Thank you.
Thank you, Santok. Love your perspective in day 2 already. So we are lucky to have you here, and we look forward to you getting out on a road trip and meeting many of the hospital leaders who are on this call today. So I'm going to do a quick review or overview of our End the Wait campaign. Again, this may be a review for some of you, and there may be new information for others. So Rebecca, if you can go to the next slide. So we are all a highly interdependent system, and it really takes all of us working together to make transplants successful. That's the OPO, the donor hospital, and the transplant center all working together as one. And like Santok said, I think we have a realistic goal set. I mean, can we achieve 116% growth in the next 5 years? Absolutely. And we have identified clear ways to do that, and we'll talk more about that. So you go to the next slide, Rebecca. Our goal is to save an additional 1,000 lives over the next 5 years by 2026. This actually was started last year. So I mean 200 organs more per year. So how are we doing if we go to the next slide? Well, we had transplanted 861 organs in 2020. We transplanted 963. So we improved 102, we transplanted 102 more organs in 2021. Well, that's short of our 200 goal. We know that it's certainly achievable, and we'll talk more about how to get there. So if you can go to the next animation here. So still have a ways to go. We certainly learned lessons along the way about the time it takes to get initiatives built and operationalized at our hospitals. That was certainly lessons learned. You'll hear more about our lessons learned later on from Rachel. So next slide. So a little bit about the people who are waiting, the people like Lonnie before his transplant that are waiting in the areas that we are all operating in. So in our service area here, which means Alaska and Washington and Montana and Northern Idaho. As of January of this year, there were 1,776 patients who are waiting and listed at the 5 transplant programs here in the state of Washington. If you go to the next one. Rebecca, there were 1,019 additions to those wait lists at those programs in 2021. So while we transplant 963 organs, not all of them obviously go to those patients waiting in Washington programs. They go to Oregon and other centers throughout the country. Likewise, organs from other areas come to our Washington program. So we transplanted 963 organs, yet there were 1,019 additions to the wait list. This just highlights the ever-growing need for more donation. Go ahead, Rebecca, to the next one. So I think the one thing we're all working towards, and what truly means end the wait, is the people waiting on the waiting for an organ and ending the mortality. So 75 people died waiting for an organ at those Washington programs in 2021. And this is our key focus. This is our North Star here. We want to make that 0. We don't want anybody dying waiting for an organ. Next slide, please. So this is our commitment to you. And what is LifeCenter going to do? We have shared accountability. Again, we're a highly interdependent system. These are some of the things that we're doing to make donations successful and to be better partners for you. So if you can hit the next slide. We have staff ready, willing, and able to partner with you. We are committing more resources. We added 26 positions over the last 6 months in our operations team to better support the donation programs throughout our service area. We've added positions in Alaska, Montana, Central Washington, Eastern Montana, Central Montana, and Spokane, be able to respond to referrals quicker. We've heard you, and we realize that's one of our biggest opportunities to be able to get to the hospital quicker after you call. Next, Rebecca, we're going to be continuing our education with you as needed. We have a fantastic hospital development team here present today who are willing to provide whatever education your hospital needs to be feeling supported with the donation program and all that we can do to partner together. Next. Again, collaboration on improvement, opportunities for improvement. We recognize donation is a high acuity, low frequency event. So even at our busiest hospital, we'll hear from today, Harborview doing 60 donors a year, that's once a week. And we recognize that this is not the only thing that you guys do. You have a lot of other competing priorities, so let us help you work through those opportunities for improvement. Next slide, or next. We want to make sure that you are aware of your performance and deliver as much feedback as possible. So we have developed tools to help you understand where your hospital is with respect to the donation program and any of the key initiatives that you are working through, how those things are progressing as well. Next. We want to make sure, and most importantly, that you are in compliance regulatory-wise. At the end of the day, what we have chosen for initiatives align with what's required of you and your conditions of participation. But ultimately, those are the things that will get us to those 1,000 additional lives saved over the next 5 years. Next slide. So how did we do in 2021? This is our recap. So next slide. So one of our key objectives was to meaningfully engage our A hospitals. For those who are not familiar with our categorization, we classify our hospitals or categorize our hospitals into A, B, C, and D based on potential, high being the hospital, or A being the hospitals with the highest potential. So we wanted to meaningfully engage all of you at 8 hospitals as part of the End Await campaign. So if you can hit next. So the question was, were we successful? And the answer was yes. So we were able to have 100% engagement with the 8 hospitals in our service area. We had over 100 leaders, including many of you, that were able to join us in one of the 3 leadership sessions last year. So we want to thank you for your collaboration and participation, and you'll hear some more of the results of later on. Next, please. So our next objective was to address the myriad of factors that contribute to missed donation opportunities. So Rebecca, if you can hit next. So, were we successful? Well, this is, we certainly have made progress, and we know we have room or ways to go. To orient you to the slide here, on the left, you'll see one of the key initiatives was early extubations, those patients who were extubated prior to LifeCenter making a determination of suitability, or the patient was extubated even before referral to LifeCenter. On the right is a number of initiatives relating to honoring donor decisions. So the blue is the hospitals that fully implemented a key initiative. The yellow is those that have partially and made progress towards implementing, and the gray are those who did not make any progress. So we had 21 of our hospitals make some meaningful progress on a key initiative. That was a lesson learned for LifeCenter, that it does take some time and resources to get going, but we are making progress, and we hope to make a lot more in 2022. Next slide. One of our third objectives was to develop some cutting-edge future state performance tools and monitoring practices. If you can go to the next slide, Rebecca, hit next one more time. We were successful. We have developed a compliance and legal donation scorecard of sorts, or report rather, which is being sent out quarterly to all 8 hospitals. We will be expanding this to other hospital categorizations later this year. But this section is really to let you know where you are with your conditions of participation. If you can hit next, Rebecca, we broke this down into a couple different sections. In the black font, you'll see the specific condition that's related to that area, and then the blue, any key definitions, if it's a LifeCenter measure, or metric, or KPI. So these scorecards are meant to kind of give you a look at your hospital's performance. You can see here in this first box that we had over 1,600 late organ referrals. If you go to the next section, this is maintaining potential donors. We had 664, or trying to scroll in here, my eyes are bad, sorry, 664 missed referrals. These were just not even referred at all. If you scroll on to the next one, unplanned mentions, over 80 unplanned mentions. Again, CMS stipulates that the OPO or a trained designated requester are the ones that should be bringing up donation to the family. And then finally is the last section. You'll hear a lot more about this year. This is honoring donor decisions. And we had almost 50 donors who have made their decision known, a legally binding decision saying, I want to be a donor, and they were not honored. And these are all the things that collectively together will get us towards those 1,000 additional lives over 5 years. Next slide. So why I think this scorecard, this report is important, Rebecca, if you can hit next, is the Congress recently asked the National Institute of Health to work with the National Academies of Science, Engineering, and Medicine to put together a study looking how do we create a more fair, equitable, cost-effective, and transparent donation system. And from this study, which was just released, the results were just released last week, they made some recommendations for immediate changes and then some long-term improvements as well. And we knew that there was an increased focus on performance with respect to OPOs, and we also knew that they'd be looking at transplant center performance as well as our hospitals. So in advance of this coming out, we anticipated that, and that's why we came up with the donation reports that are being sent out to each one of you quarterly. Rebecca, if you can hit next, one of the recommendations that came out was for CMS to update its interpretive guidelines to reflect current practices and promote a collaborative relationship between the donor hospital and OPO, and specifically institute measures, measurable reporting mechanisms for hospital level data, and to address this systematically through your CMS surveys, and including the Joint Commission. So that was just something that they have recommended. So I think we're one step ahead of this. We are doing our best to share data back and forth and work collaboratively. So we're ahead of this. I'll just, if you can hit next, one other recommendation that they're maybe coming down the pike is exploring financial incentives and making changes to interpretive guidelines that make hospitals accountable for what they're calling smoothing the surgical scheduling, make sure that organ procurements are available every day of the week. So again, just some more coming down the pike for you, but I think we're well out in advance of any of these recommendations with our reports that come up to you, so you can see where your hospital is with respect to any regulatory compliance. Next slide. And one of the final objective was to work with all of you again to make sure that more donation decisions are being honored so that we can save more lives like Lonnie. So if you can hit next, the question always is were we successful? And our conversion rate remained pretty flat throughout 2021. We did see an increase in organ potential. So when I go back to and think about, was those 200 extra lives, additional lives, realistic in 2021? The answer is yes, because that number was based on a certain growth in our donation potential. And we actually seen a larger growth in 2021. So we could have saved 267 more lives if we had met our conversion goal of 60%. We weren't successful in honoring more donation decisions. In fact, the donor registry oppositions increased 1% from 6.6% of all potential to 7.6%. So I think this is something we're going to be able to make some progress on this year, and you'll hear more about later today. Go ahead and hit next, Rebecca. So I'm going to turn it over to Rachel Hawk, our Hospital Development Director, who will be talking about the cost-benefit analysis of process errors. Rachel.
Thanks, Dominic. So I think Lonnie did an excellent job of showing us the benefit of not missing organ donation potential. I think it's pretty clear what the benefit is. It gives people their lives back. It allows them to see their grandchildren be born and see all those meaningful life events that we all enjoy and appreciate. And I think the cost to those on the transplant waiting list is very clear as well. Those 75 people that died waiting for those life-saving organs, clearly that's a huge cost. One of the things that we don't often talk about is the cost to the hospital when an error occurs or there's inefficiencies in the process, and the time, energy, and resources that are required for the hospital staff to put into play whenever there is a process error. So today we want to look at what is that cost to the hospital in terms of those time and resources that are required. And then what are the challenges that are contributing to that current situation? And then also, what's the opportunity to maybe limit some of those costs in terms of the amount of time required to follow up on those. But first, we're going to do a little interactive poll to see how well you all might know whether or not how long these things actually do take. So if you go to the next slide, we have our first poll question. And so this is a part where you guys get to vote on your answers. So on average, how much time do you think your hospital spends following up on process errors resulting in missed organ donation opportunities per year? And the choices are 2, 6, 12, and 23 hours. And Rebecca, if you can put the poll up for everyone to vote, go ahead and submit your guess estimate. And then Rebecca, you let me know when we have a critical mass of people who have voted so we can look at the suggested answer.
All right, I think they've slowed now. The answer's coming in.
Okay. Okay, so what is the guess? Okay, so actually the 46% is correct. The answer, if you click next, Rebecca, is 12 hours. So this is on average each of the busiest hospitals. So that's, as Dominic was talking about, those A classified hospitals, which is all of you on this call, you do categorize in that largest hospital, spend an average of 12 hours following up on those missed opportunities that we've talked about. So the next question is, on average, how much time do you think your hospital spends following up on late or missed vented referral process errors per year? And the choices are 11, 17, 32, and 49 hours.
All right.
Okay. So actually, it's more than 17. So the answer, Rebecca, is, you can reveal, 49 hours. So close to 50 hours is spent following up on those late vented referrals per year, process errors that happen for that process. So if we go to our last question, is on average, how much time do you think your hospital spends making initial referral calls per year? So this is that pick up the phone, call us, let us know that you have a patient that might have organ donation potential or meets the clinical triggers. So 23, 55, 97, or 146 hours. Okay, so 97 hours. That is the answer, if you can reveal, Rebecca. Yes, so on average, 97 hours making the initial referral calls per year. So if you go to the next slide, we'll see what the combination of all of these process errors and inefficiencies within the system add up to. So in the current state, you're looking at about 158 hours following up on those missed opportunities, process errors, and making that phone call, which we know is not the most efficient way to notify us of referral calls. So on the next slide, we'll see the challenges to the current state. And we'll kind of walk through these, starting with the high acuity patient. And we know that over the past couple of years, the acuity level of patients has actually increased. Our nursing staff and healthcare team members are busier than they've ever been. They're dealing with complex family dynamics and visitation policies and things like that, and near constant change over the last 2 years. And that was a challenge even before COVID, and it's only increased with COVID, making it more challenging to do the job that they're being asked to do. And moving on to timely referrals, we've talked about how that's not an efficient process in order to make a referral. You have to think, well, is the phone close by? Do I need to step out of the patient room? Is the patient's family in the room? How long am I going to be on hold for this call? And it really disrupts the workflow of the healthcare team taking care of the patient. And in addition to that timely referral challenge, there's also decision fatigue. And the nursing staff, we know, are making lots of decisions and trying to take care of multiple patients, and may have questions like, am I giving up too soon on this patient? Or is this even the right time to make this call? Should I make it later? Is it too soon to make this call? What are the requirements? And what's my personal decision about donation and how that might impact whether or not I make this referral call or not? And finally, we know that hospitals over the last couple of years have been relying heavily on traveler nurses, or maybe have newer nurses on the unit that have less experience and less knowledge, and often can be overwhelmed by a situation or may not readily recognize when a patient needs to be referred to LifeCenter. So with all of these, we know that each of these are contributing to those process errors and those missed opportunities, as well as inefficiencies within the system. So on the next slide, we'll look at what we actually think is possible. So we talked about those 158 hours that currently make up all of these combined. And our opportunity, if you click next, Rebecca, is really aligned with what we're asking today within the wait. So if we were to eliminate the missed opportunities and eliminate missed and late referral calls, those numbers would be down to 0. Recognizing, of course, that we don't think that probably all of these will be eliminated overnight. But if you think about it, every single one that is eliminated, it ticks down those hours up above to a lower number, and allows those nursing and healthcare team members to be able to focus their attention on things that are needed. So one of the things that you're probably all very interested in is how do we go from 97 hours to 24 minutes? And that really is what Dominic was talking about with the automated referrals, the electronic referrals. We know that in this day and age, you don't even order food by picking up the phone. You get on an app or get on your phone and make the order, and then people bring it to you. So it's really kind of bringing the referral process into the here and now. So with that, we will talk a little bit more about that coming up later in the agenda to talk about how we can get those numbers down even lower and have that 99.7% reduction in the cost of time, energy, and resources required for these inefficiencies and missed opportunities. And luckily, all of this work lines up with that big benefit of helping people like Lonnie be able to have their life saved through organ donation. So with that, we're actually going to transition into some of our hospital highlights, and we will go to the next slide where I'd like to introduce one of our hospital representatives, Brandy Cornwell. She is out of Benefits Health System in Great Falls, Montana, and she's the manager of surgical services and endoscopy, and she's been our donation program coordinator for many years. And in 2020, Brandy was actually recognized as the LifeCenter Donation Champion of the Year for her ongoing collaboration and commitment of donation at Benefits Health System. She plays a vital role in all aspects of the donation program and was a key stakeholder while implementing a key initiative as part of LifeCenter's End the Wait campaign. And I'm also going to invite Mallory Wood, who is the Hospital Development Program Manager for Benefits. And she's going to be talking with Brandy about the work that they did to reduce extubations while following last year. So I will turn it over to you, Mallory.
Awesome. Thank you, Rachel. Brandy, thank you again for joining us and sharing with our hospital partners about your key initiative. I know following the launch of End the Wait last year, Benefits had a very large goal of reducing to have 0 extubations while following. Can you tell us a little bit about your key initiative, which was tied directly to that?
Yeah, absolutely. So we implemented a terminal extubation timeout checklist prior to any patient nearing end of life to ensure that we are following all of our processes and checklists to make sure that our providers are on board as well. And the goal really was to ensure that we were not pulling that endotracheal tube prior to LifeCenter Northwest closing out to continue our end of life care to that patient.
Awesome. And I know a little bit further below, we'll talk about what's included in that timeout sheet. But can you share how you guys kind of identified why this would be your key initiative?
Yeah, so we very much jumped on board to the End of the Wait campaign over a year ago and really took this task forward to help decrease those patients that are waiting and having the missed opportunities come out of the health system. So it was very clear to us where our goal lied. Our administration team 100% supports us in this goal. And so, like I said, it was very clear that our missed opportunity was really extubating our patients while LifeCenter Northwest was following.
Absolutely. And I think you guys took a couple of different angles of, looking at this, seeing where the patients were, transfers, all kinds of things kind of played into this. But what I love the most is that you looked at your data to really pinpoint what area had the highest risk. And then during the last year, we kind of learned through creating and implementing that timeout sheet what was working. So can you talk a little bit more about what some of the strengths and challenges were with that?
Yeah, so to talk a little bit, this very much was a grassroots effort from the ICU manager and Patty Beal and our ED manager, Scott Shandelson. And our structure is that we also have a critical care director that manages both areas, Kevin Langkite, and they were very much instrumental in helping me bring this forward to Benefits because as I manage the operating room, I don't manage their teams. And so they very much were on board and really created the process of the terminal extubation checklist. So that was our number one strength, is that we were all on one team working towards this goal together. like I said, our team had to bring this forward to our ICU team, who has a very strong foundation of referrals to LifeCenter Northwest. We are at a referral rate of 99% to 100% at end of year, just depends where our end number falls. So we have a really good foundation that our patients need to be referred. What we struggled with was a challenge that we had was to ensure that our providers were on board and they weren't intervening. And so that's an area that we continue to work on with our mid-levels and our MD intensivists that work alongside with our nursing staff. We obviously were able to initiate education really quickly because we had such a strong foundation for all of our vented patients being referred to LifeCenter Northwest. And then we have, I would say, a really strong foundation for timely reporting of missed opportunities. And so I get every death in the organization along with the ICU manager. And we both tag team those to make sure that if there is a missed opportunity, we jump on that right away and do a debrief. Because if we're waiting for death record review, that can take some time, and all of those thoughts of why this occurred, it's really hard to play back a month to 2 month time to recreate what that looked like. And so those are kind of some of our strengths that we have here at Benefice going through this process. For another challenge that we have is just really working with LifeCenter Northwest, and more information is coming from your guys' side on this, is really having clear communication on, is this patient ruled out? Are we still following this patient? Is this case closed? And so really getting that message back to the clinical team, and as nurses transition off of their shift and new nurses getting onboarded, did that information get passed on that this was a closed case, or is LifeCenter still following? And so I'm excited about the opportunities that are going to come forward with the language change there. And then one challenge that we continue to see is that this form is not going to prevent a missed potential if the case was closed. So if this patient was closed and has gotten better, but then declines, if we don't make that re-referral, there could still be a potential miss. And so that's something that we are just continuing to educate to our staff and to our providers.
Yeah, absolutely. And it's exciting to hear the language changes coming, and knowing the direct impact that those have on your timeout sheet is something hopefully we can help turn around at the beginning of Q2 with our new language coming soon. I'd say from my perspective, another strength was your guys' willingness to reevaluate and continue to reevaluate the checklist to see what might be missing, what wasn't working in the flow and the process. And you guys did that on a really regular basis until we really fine-tuned what worked best for the healthcare team. And that included bringing different departments from both LifeCenter and the hospital together to have those conversations so you guys could really achieve your goal. So looking back, if you could give kind of any advice for people that are just starting or in the early stages of their key initiative, what would that be?
My biggest thing is getting all of the leaders from all the departments in one room for them to really understand what the impact is through LifeCenter Northwest and how this process is going to impact them. Kind of going back to those numbers that Rachel shared of how many hours this takes for our care teams, and the opportunity that it will save us time in the future. When you're in the grind, it's hard to see that sometimes. And so if we can all get in the room together, we 100% on our side have great support from our medical directors as well. So that really helps us with provider concerns that we may have or opportunities for improvement. And so if you can just get all in together and have that conversation, and for everybody to understand what the impact is going to be on them, and understand all of the rules that go along with donation as well, I think is very important, because that can help drive the support for the program. Another thing is really just giving our providers that bridge language. There's that awkward time between the fact that they're having those end-of-life conversations with the family, and then the care team cannot bring up donation. And so making sure that the providers are comfortable with that bridge language and comfortable, with that 15 to 30 minute downtime prior to LifeCenter getting onboarded. Great Falls here had a great impact. We were very excited about the new additional member to our team as we are very centrally located away from everybody. It's hard to get to our area. And so I think that is going to be a great asset to helping us with our key initiative as well.
Awesome. Well, thank you, Brandy, for sharing. And I do want to thank Kevin, Patty, Scott, and Rain, who also played really vital roles in the implementation of your key initiative. And thank you again for your time today. It's always a pleasure chatting with you.
Great. Thank you, Mallory and Brandy. We really appreciate it. And what I love to hear is the great collaboration that you both have with each other to identify, what are the things that we can keep improving and what are we learning as we move forward. So now we're going to turn our attention to Harborview, and I'm going to invite Ross Brownell, who is our Hospital Development Program Manager for LifeCenter, who works directly with Harborview, and he's been working with Harborview for about the last 2 years. And their focus last year was reducing early extubations. So he and I are going to have a little conversation about all the work that they did at Harborview around this. So Ross, we'll just start off with recognizing that early extubations aren't a new thing that hospitals are challenged with, and that we've been working on them for many years. I'd love to know what happened last year that you see as maybe different that wasn't done previously at Harborview and what you learned.
Yeah, you're right. Let's make sure. Can you hear me too? New sound system I'm working through here. Yeah, okay, fantastic. Yeah, you're absolutely right, Rachel. Extubations is not a new thing, but it was the main focal point of what we were working on for 2021. I think what I wanted to do differently, and Rebecca, we could go to the next one there, is kind of just grab attention for those in the hospital on what this meant and what extubations were, really trying to show them, what activities threaten donation the most from a process standpoint. So kind of a different approach. I wasn't entirely sure how I wanted to go about everything. Harborview was new to me. I started right when COVID started, then I went on paternity for 6 months. So I have to tell you, in that first year, I really didn't get to know that hospital as well as I would have liked to. So coming into 2021, it was, here are some general ideas, and then I'm going to go through the year and try and explore and identify where I really see those issues are, and then move from there. But we want to do different, and we can go to that. We can go to the first two there, Rebecca, and then even the next one there, I think, is just letting people know from a data standpoint where we stood on the extubations. We wanted to reduce those by 50%. We had a lot of RN buy-in on that, and there was a lot of communication with the RN managers. But this is a wholesale process, and so I wanted to make sure that there was MD awareness to this as well, as they're the primary members of the team that are moving the care. So I sent out monthly data, and it was very much focused a little bit differently than we had in other hospitals, where here's just your donation potential and all of those things, which are all very important, but very much focused on, here are the process pieces that we're trying to fix with this key initiative. It went to a much larger audience than I had previously sent reports out to before, from C-suite all the way down to just about anybody I could get an email for, trying to create that awareness of what we were trying to do. And what the extubations meant. There was a different focus for the RN managers on how they would follow up with their staff when these events would take place. And not to say that we wouldn't follow up with any of the other process pieces we're always looking into, but very much a focus with their team on when extubations would take place, how to prevent that and what that meant. But on the side, working with the RNs on all of that, there was a definite goal on making sure that the MDs were involved and there was an awareness there. There was, I think, always appears to be more of an overarching, and I think this exists everywhere, feeling that this is an RN thing, and it definitely is a wholesale project and effort by everyone involved. And so the goal was to try and at some point create some type of MD form. I wasn't entirely sure how to do that. So that's why the data to create the awareness is how it started. And that just kind of rolls into that last point there, Rebecca, you want to go there? And so that's kind of how it went. It was just more of a saturation of data and awareness throughout the year, and having those individual conversations so we could kind of address how to get that forum created.
So it sounds like initially you were just trying to build awareness, make sure that everybody and anybody who might be interested was aware of the early extubation data. And then at some point, something shifted. So what would you say would be the turning point to where you actually kind of moved into action or started to figure out what it is that you wanted to do once the data had been examined?
Yeah, and we go to the next one there, Rebecca. I think with anything, we are coming from an external standpoint at the OPO, and which is important because this is a partnership to help the hospital know where they stand on a lot of things. But really the turning point, I think, for the conversations that were had after the fact were when we did get some internal buy-in on that of activation of addressing this problem within the peer group of the MDs. And I have a nice advantage at Harborview that we do have our medical director, Dr. Suter, who's chief of anesthesia there, who was looking at this data and seeing this data. And I think it was around August that I sent out the reports again, showing the extubations where he felt, okay, this needs to be jumped up a notch a little bit from peer-to-peer conversation. And that is not to say that Harborview was doing a terrible job, because they weren't. There were a lot of great conversations within that time, but really addressing it within that peer group. And you can see just from his first quote there that this is more than just an OPO thing, that this is a hospital and OPO combined effort to make sure that not only are we working through those CMS regulations, but understanding the need. And he did go to a critical care meeting in November and kind of address this and lay this out to his team. And I think one of the biggest pieces is that was showing the lives that are lost on a daily basis, and the need for why we're doing what we're doing, not just from a regulation standpoint. And so you can see just in his first quote that all the things that need to be done from a partnership standpoint. Moving into that, it's how does that happen, right? It's philosophical. We want to do this, but what needs to take place? Without any type of internal system, then you're looking at the OPO, as we talked about earlier, with all those process follow-up situations within the hours that are spent on that, are on a case-by-case basis, where it's brought to our director, it's brought to the individual, and there's some quick follow-up, and then, okay, I'll think about that, and we move on going forward. But there's nothing necessarily systematic about that. And so it's kind of a spot, kind of Band-Aid on the situation in that moment. So moving to his last one there, it really was a point of his that internal QI systems be created, which was great for me because it was kind of where I wanted to go the whole time. I wasn't totally sure how to get there, but the data that was being sent is just part of what he's talking about in that last quote, and then the creation of those internal QI systems based on that data of how you follow up, how you address it when they happen, what is going to be the results of solution, and how do we address that when those events happen. So really a wholesale approach of philosophically why we want to do it, here's the partnership, and then what internally are we doing from a QI standpoint to make sure that the data we receive from the OPO is now being taken and used the right way.
Yeah, so it sounds like it took most of the year to kind of get to a point where you were ready to identify what the solutions were. So I guess my final question is, what are you most excited about that is in process now that we anticipate this year happening?
Oh, excited about so much. We can go to the last slide there. I will say that the hospital the conversations that came out of that meeting have been great. And the hospital was engaging the entire year. Harborview was doing a good job, and we were coming up with a lot of different solutions. This just was kind of the last piece of the puzzle. So what we'll be working on, and this was agreed upon within that critical care leadership meeting that he had, was working to create the structures of an internal QI system. Those conversations are currently happening. How do we want to record that? What's the mechanism to follow up? How are we going to create those solutions? So they're currently working on that. I would say that's a Harborview thing here on our Venn diagram, but it is a mutual effort. Then the next one, through all of these conversations that then happened, you are then also aware, and in reviewing it from our end, things that we needed to get better at from a clear communication standpoint. So we noticed that maybe we weren't charting in the most clear fashion. Sometimes we get tied into our own jargon and we think that makes sense to everybody else, but it doesn't necessarily. So eliminating abbreviations and just having some clear, concise, and I think Brandy talked about it, close out versus rule out, kind of language that really defines that type of thing, and what our intentions are. The third one, we came up with, once again, going back to, does the language we use make sense to the hospital? And I asked medical ICU manager when they were saying, well, when you round, we're not 100% sure on what you want and who we should be looking for. So I asked them to come up with a script that would make sense to them, specifically in what we're looking for as far as a patient that needs to be referred, or the progression of a patient that we should be following on if they're getting ready to move to comfort measures or anything like that. And they came up with a 4-question script that our team will hopefully, starting April 1st, be asking every time they round in all 4 ICUs at Harborview to better identify who we're looking for. And that was great because it was language that came from them. So there was some nice ownership there. And then the final one, been working with specifically with some of the physicians in neurology and neurocritical care services on communication protocols on when our team, who they are talking to from the progression of a referral to a family approach, whether it be the resident, the fellow, the attending, the RN, whoever's involved, and at what points, whether brain death testing is involved, whether we're about to have a family care conference, that type of thing, or whether it's just a daily follow-up and nothing's really changing. So that communication protocol that we would hope to pilot in the neuro ICU and then roll out to the rest is all the things that we're working on.
Well, those are very exciting, Ross. Thank you for sharing. And I think it really goes to demonstrate how it's a collaborative effort. It's not just the hospital doing something or LifeCenter doing something, but when we come together and work together, we can identify what are those key things that the hospital can do, how can we support it, and then what do we want to work together on to make sure that we have a good system and foundation to ensure positive donation outcomes. So thank you very much for sharing that information. And our final hospital highlight is Valley Medical Center. And I'd like to introduce Donnell Chandler. She is the critical care nurse manager and our point of contact for organ donation at Valley Medical Center, and she has been for several years. She was pivotal in 2021 in intervening quickly and early to find a solution to our key initiative, which was focusing on eliminating missed referrals and eliminating early extubation. And we are so thankful for her unwavering commitment, even through the most challenging times of the last year, and her outstanding collaboration with us in organ donation. And she will be joined by Priyanka Joshi, who is the Hospital Development Program Manager for Valley, and they will be talking about the key initiatives that Valley implemented. So Priyanka, I will turn it over to you.
Thanks, Rachel, and thank you, Donnell, for joining us today. A lot of us have had the opportunity to work with Donnell, and we know that she's a perfectionist and she takes action immediately when there's a problem and finds a solution for them. So Donnell, in looking at missed referrals, what was your thought process to address your key initiatives, and what change did you make?
So I think if you will go to my first slide, let me go ahead and talk about that. I've been in the critical care unit here for 4 years now, or coming upon 4 years. And we continue to have goals for our referrals that continued to rise, but our last goal had been 90% for 2021 and 2020. And we just weren't getting there yet. We had, regardless of the education that we provided quarterly, every quarterly staff meeting, we continued to speak of organ donation, tissue donation. It was always a focus in our staff meetings. And in the moment education with our staff, but we, as everybody started having increased turnover, a lot of travelers coming in. And so we needed to figure out a way to mistake proof this. Education wasn't the only answer. And so we looked at leveraging our EMR, our flow sheets in our electronic health records to help us improve those missed referral rates. And you'll see on this slide here that as the year progressed, or the backside, as the year progressed, we did continue to increase our referral rates. Now, next slide, please, Priyanka. So what we did is whenever we had an intubated patient, that ET tube LDA would create this section of our complex assessment flow sheet. So we called it potential organ donor referral. And it gave us a place, instead of a piece of paper that we previously utilized, gave us a place to document the date and the time that a call was made, as well as that referral number. But it also gave us the option of putting in, yes, this patient is going to continue to be followed by LifeCenter, or no. And on those, we added some items to help us with improving even our extubation prior to calling LifeCenter, with the do not terminally extubate without calling LifeCenter first, as well as remembering our tissue partners after the fact, is that we also need to call after we had a patient passing. So instead of relying on the memory of a traveler from something that they were told, or our own staff not even maybe going over it, because in that short amount of time with our travelers getting that education, we've provided a visual alert to remind people, hey, is this somebody that you need to call on, and or has this patient been called on?
Yeah, so that was really great. I feel like the flow sheet not only had everyone calling the referrals timely, but also making sure that they were not extubating that patient, and they kept seeing that do not terminally extubate without calling LifeCenter. So great job on that, Donnell. And you took action early and you implemented it quickly. So what was learned throughout the process, and what was the impact of this change? Do you think you'll do anything differently in the future?
Yeah, definitely. Thank you for asking, Priyanka. I'm really proud of this part, just because I think that it is such a great alert to our staff. But in addition to that, we continue to have opportunities. We're going to work on an extubation checklist, just like the lady from Venice had talked about, so that we will continue not to miss referrals prior to terminal extubation. Even though it's here in this flow sheet, we've identified that we have another opportunity to just have a successive check. And we'll do that in relationship with our respiratory care providers to help us, as well as it is a team to make sure that we provide the right care and do what's right for not only the patient that we are taking care of there, but future patients who will be receiving the gift of life.
Yeah, thank you, Donnell. I mean, your success is attributed to your strength. You change culture through conversations and building relationships, and you do such a great job at that. So thank you for doing that, and thank you so much for collaborating so well with us. We really enjoy working with you in good.
I do want to mention, Priyanka, the other thing, I talked about working with our respiratory care providers, but it's also working with our LifeCenter partners as well. And, I talked about the education, but utilizing yourself to help keep our travelers that are here coming in consistently, as well as our regular staff working with you to continue that education for them, in addition to the visual alerts. So thank you for your partnership.
Yeah, and thank you. And I know that Donnell's making an effort now to have us go in regularly and train their travel staff as well, because I think the travel staff is more than 50%, and she's doing a great job at keeping us involved more regularly. So thank you so much.
Well, thank you both for that. That was really interesting. And I think one of the things that we can tell is that there's no one size fits all for the hospitals, that there's different things that will work in different units and different hospitals. So what I want to reiterate is that LifeCenter is happy to help and examine what might work and help you implement whatever works best for your hospital. So now we're actually going to turn our attention to year 2 goals and objectives for In the Wait. Dominic did a great job of talking about how we did in year 1. So now we're going to talk briefly about the lessons learned and then what we're looking forward to in year 2. So if we'll go to the next slide, we can see some of our lessons learned. The first one was actually to expect the unexpected. And I say that primarily related to COVID. I think last year when we completed our leadership summit, we had just found out the vaccines were being distributed. Everybody was feeling really good that perhaps COVID would not be as big of an issue in 2021. And then August, September, and October happened. And we know that Delta actually made it quite bad for our hospitals. And what that meant for us on the LifeCenter side, and particularly related to this campaign, is we actually saw an increase in our missed opportunities during those 3 months. And it wasn't for lack of trying by our hospitals, but it was because of some of those challenges that I mentioned earlier related to the nursing staff being so busy that sometimes they would make the referral call, but they literally wouldn't be able to take our call after they did because they were so busy caring for patients. Things were moving more quickly, patients were extubated more quickly because beds were needed, staffing was short, and even meetings to address some of those missed opportunities or to continue to work on the key initiatives that were underway had to be canceled because so many of the leadership was actually needed on the unit to care for patients. So expecting the unexpected and just rolling with it and trying to make the best of it was definitely a lesson learned. The next lesson was around the timing that it takes for foundation and exploration. I think Ross did a great job of explaining it really took till August, September to figure out, what do we need to do? What's the data telling us? And we had many hospitals who had an idea for a key initiative and then pivoted as we went forward. They realized, oh, this is not going to be working the way we thought it would. We should do something a little bit different. And our next learning was that we needed to narrowly define our initiative. So last year we had given the hospitals a lot of options in terms of timely referral, collaborative conversations, donation culture. But what we learned is that working on those didn't necessarily prevent those missed opportunities. The things that prevented the missed opportunities was not extubating the patient and honoring donor decisions. So you will see in our objectives, those are the 2 very defined initiatives that we'll be asking hospitals to focus on for the coming year. And the next lesson was that we really needed to make sure that our hospitals, after they implemented the key initiative, had a mechanism for tracking. Are we actually using whatever initiative we've implemented? Is it having the impact that we wanted? So that'll be something you'll hear from our program managers this year, encouraging you to create systems to ensure that once something is implemented, that we are tracking to see if it's being used and if it's effective. The next learning point was actually something I think that Brandy mentioned, is that we didn't realize the impact of the re-referral. We were really excited to see that last March, so right after our leadership summit last year, we saw our referrals increase significantly, particularly from our largest donor hospitals. So we were very excited to see that that was happening, and we believe that that impact is actually from some of the work that we did with the In the Wait work together. But we didn't realize that some of those patients would be referred and then perhaps they would improve, or they might stay static for a period of time to where LifeCenter would stop following. And then there was that period of they might get extubated before they're re-referred after they have a decline in their clinical status. So we, as Mallory mentioned, are working on internally our language to make it clearer for hospital staff when they need to re-involve us if they have a decline in the clinical status of the patient. And finally, we learned that we need to identify a clearly assigned accountable person for the hospital. So in each one of our hospital highlights, it's clear that we had one person that, not that they were the only person doing the work, but one clear accountable person who was going to be driving the initiative forward and making sure that anyone else that was contributing was kind of doing the things that needed to be done. So a little teaser here, we're going to be looking for an accountable person for each one of our hospitals to make sure we know who to go to should we have questions about how the initiative's going or what we can do to move it forward. So those were all of our lessons learned, and it really did inform our campaign objectives for next year, which as we move to the next slide, you'll see are not very different from the campaign objectives for this year. So our first one is actually to just continue the good work that we're already doing with all of you. And that's really to build on the success that we've had in the year 2021 and continue with tactics that are already in motion. We don't want to reinvent the wheel. We know that there's a lot of good work already happening, so we want to see that through to the end. The second objective will look familiar. It's also to continue the work on addressing those items that contribute to missed opportunities. This is really focused on those early extubations that we've been talking about and making sure that we have systematic things in place to address those and not relying on just the education, but as Donnell said, really mistake proofing any of those processes in the hospital so that we don't have those missed donation opportunities. And the third one is related to honoring those donor decisions. And we'll be talking more about that. I'll talk in just a moment about an upcoming session in our leadership summit that is focused directly on that. And the next one is related to the cutting edge future state performance tools. So Dominic already reviewed our CMS and legal compliance report. And with that, you'll be continuing to receive that quarterly, but we're also adding 2 different mechanisms to show you how your hospital's performing on both the early extubations as well as the honoring donor decisions and the processes for building systems to ensure that those go smoothly. And so you should be seeing those in April, and that should give you a good idea of what work your hospital has done and what work is still ahead for them. And finally, the last objective is really expanding this in the weight. We started last year with our largest hospitals, primarily because we knew that would be the biggest impact. But we aren't satisfied with just impacting our largest hospitals. We want to make sure that there is no missed opportunity for donation throughout our whole service area. So we will be rolling out the End the Wait campaign to all of our hospitals starting in 2 weeks. And so with that, I will go to the next slide and give a quick plug for that additional summit session that I mentioned on March 30th. And this is really going to be focused on honoring donor decisions and having a panel discussion about many aspects of that donor registry and making sure that we honor those decisions. And if you haven't RSVP'd, we'd really encourage you to do so. We think it's going to be a really great discussion with a lot of good information. And with that, I will turn it over to Dominic for the part that I know all of you have been wondering about since early in this presentation of how do we get to 24 minutes?
Yeah, thanks Rachel. And, you know, I was excited to see the work that Donnell and Priyanka were doing with the flow sheet, and it just kind of, you know, follows really well, leads in really well into this presentation here. So if we go to the next slide. So electronic referrals are not new. In the industry. This is not something that just started yesterday. So there's been a lot of work being underway to move away from those phone calls. And the Cleveland Clinic, New York Presbyterian hospitals in Texas have already worked through this, whether it's through their own data or an IT team or through their electronic health record like we're looking to do here. So LifeCenter partners with a group called Transplant Connect, and we use the iTransplant platform. So they call it the iReferral. Some others call it the e-referral. I think what we're trying to get away from is the you referring the patient. See what I did there? Get rid of the you referral. So if we go to the next slide, the objectives of having an electronic automated donor referral are to eliminate the phone call. We talked about going from the 20 minutes to the 5 seconds. How do we create how do we create triggers for those donor referrals? So it's not reliant upon training and education of new travel nurses. How do we make that automated? How do we create best practice alerts? I know that's a trigger for some people because they're tired of seeing best practice alerts, but how do we create a best practice alert so saying, hey, this patient meets criteria for donation, would you like to make the referral? how do we securely deliver that referral from the hospital EMR to the OPO? Again, liberating staff, nursing staff, and allowing an OPO call center staff rather, catch those missed referrals or those late referrals, and increase, again, referrals, donation, and transplantation, all with the goal of ending wait. So our Transplant Connect has already partnered or has availability to operate or create APIs with most of the EMRs out there, Epic, Cerner, Athenahealth, Meditech, so on and so forth. So how does this work? So Rebecca, if you can go to the next slide. So this is a sample of how it works with Epic. So it's already available in App Orchard with Epic. So essentially, Transplant Connect, LifeCenter, and the hospital will partner together to identify what are those triggers. So is it a GCS score? Is it patient being intubated? Is it a goal of care conference? Whatever it is that we do, that will be a trigger for a best practice alert or whatever the hospital feels is the best process. That will be implemented in their flow sheet. Once they accept that or say, yes, we want to make that electronic referral, that sends a hook or a call essentially to the Transplant Connect's system saying, hey, there's a donor referral. Transplant Connect then reaches out to the FHIR system in Epic and saying, do we have permission, so on and so forth. They get permission. That Transplant Connect will then query the Epic system, get all the information, and then on that flow sheet magically will be a referral ID posted all within 5 seconds, and that information will be directly uploaded into our system. So this is proven. Again, it's already working. It's in App Orchard through Epic. It's available through Cerner Hub. And again, if it's not available in other ones, they have a direct API built for most of the EHRs out there. So LifeCenter is ready and willing to partner with all of our hospitals on developing automated referrals. Again, Rachel pointed out the cost-benefit analysis. We really think this will have a positive impact not only on your teams, but it's a more cost-effective, efficient process, and will lead to more referrals being made, less referrals being missed, and more transplants being realized. So we're super excited about this. If you are interested in exploring this with LifeCenter, please reach out to your hospital development program manager, many of who are on this call, and we will partner with you to see what the opportunities are and explore this further. So again, this is something that we are going to be pursuing and would love to partner with you on that. So next slide. So as Rachel identified, I think the next step is for us to look for some commitments from all of you. We heard from Brandy and Donnell and Ross's everlasting pursuit of that resource at Harborview. And what we found, Rebecca, if you go to the next slide, is really identifying somebody who's accountable. We're all, most of us are probably familiar with the RACI matrix, right? Responsible, accountable, consulted, informed. And we found that most of those initiatives that were successful or had meaningful progress was because there was somebody who was accountable for the outcome of that initiative. There was a lot of engagement early on last year, but without having that true person who's accountable for driving the process forward, we found that those initiatives often took longer or have not started as of yet. So what our ask of you is to identify somebody from your hospital who's accountable. We need a Brandy, we need a Donnell to help us help you. And what we want to do here is work through all of these key initiatives, help you strategize, and really come up with the best process that's going to be the best outcome for donation. So expect to be hearing from from your respective hospital development program manager tomorrow. And we'll be looking for commitments, and we'll be looking for continued success and being able to share your story like we shared benefits in Valley today in Harborview. So with that, we'll now turn it over. We have a few minutes for questions. I just wanted to say thank you on behalf of all of LifeCenter, on behalf of the people waiting for transplants like Lonnie was. They're really dependent upon us working together collaboratively to make their next series, steps in their life meaningful, and allowing them to spend time with their grandchildren, enjoy another anniversary, and walk their daughter down the aisle. So Lonnie, thank you for sharing your story, and we'll open it up to questions.
One for Donnell specifically, how did you implement that prompt about calling before extubating?
So that was something that I worked to develop with our informatics analysts with Epic. So they were just able to create a flow sheet, and with that yes or no answer, it's just tagged at the end of it. So when you click on yes, it will have that prompt at the end just stating, do not extubate before calling LifeCenter. And then you can see that in your last filed section on Epic, so that as you flow down your flow sheet, it's just constantly there.
Thank you. Another request, can we have a copy of the timeout checklist?
Sorry, had to unmute. Yes, we will get that over to Mallory and then she can send it forward.
Thank you. It says, what were the 4 rounding questions used? To
Oh,
you,
you got me
Ross,
on the
I
spot.
think.
Yeah, I'm looking for those now. I can put those in the chat if that's helpful for everybody.
Sounds great. Any other questions while Ross looks for the rounding questions? Can we get email contacts for these presenters so we can ask a few questions about their processes? Brandy and Donnell, would that be okay with you?
Good on my side.
Okay,
Good
great.
too.
Great, thank you so much. Anyone can have a pop-up or checklist in Cerner they care to share. Oh, anyone have a pop-up or checklist in Cerner they care to share? Anybody using a Cerner program? I don't know if we have any other Cerner users, or maybe, but they don't have a pop-up or a checklist yet. Right, if you can see the chat, Ross just posted the questions there. And thank you for paving the way, Cerner.
And if it'll be helpful, I think we can also email out those 4 questions as well. So.
And just for clarification on that, where that came about, we round on every ICU at Harborview on a daily basis, and these were the specific 4 questions that we wanted to ask. I was grateful that the RN team and the MICU came up with those questions, but it was to just, we're also handing that out, those questions out to the RNs on those units, so they're aware that the LifeCenter team is going to be asking these on a daily basis. And so we're going to be spending this month sending those out. They're going to have copies of them so that they're ready and prepared for why that specific script is being asked every single day.
We'll give another couple seconds for questions. If not, then I'll send us off. I want to thank each and every one of you for your commitments to making donation successful. I think Santok said it well, that I think we have realistic goals. And at the end of the day, the numbers, all of those things equate to more people being able to share meaningful experience with their loved ones. And that's what it's about. We do this on behalf of the generosity of the donors and the donor families, but none of this happens without us all working together. So your engagement, your participation is critical for the success of the entire donation and transplantation program. So we thank you for your commitment, your engagement in this series. Again, we have 2 more of these coming up, one with our BNC hospitals, and then we'll have our donor registry support or initiative honoring donor decisions later in March. So we hope that you'll attend that as well. If you have any questions, about these presentations, or the initiative in general, please reach out to your hospital development program manager. I know Santok and I and Rachel look forward to coming out and seeing you all in person really soon, along with your hospital development program managers. We wish you all the very best, and hopefully, like Santok said, we're on the back end of this curve of pandemic and we get back to some sense of normalcy. But wish you all the best this week, and again, thank you all for your commitment.